Oh, hey, Donna.
Um,
Um,
oh, there we go.
there it is.
Yay!
Welcome.
How are you doing?
I'm doing great. Donna, we have Jake with us as well.
Hi, Jake.
Hey, how's it going?
Good. How are you?
Doing great.
Awesome.
Jake, could you just remind us, who you are and what you're up to?
Okay, so my name is Jacob Gallion. I'm the Senior Geographic Information Systems Analyst here at Riley County, Kansas. Basically, we, maintain all the data for the city and the county, city being Manhattan. We also, manage the GIS website, manage all the geographic information data, applications and whatnot. So that's kind of what we do, probably similar to what GIS folks do at other counties.
Awesome.
Yeah. So Donna, you know me as sort of our liaison, the community liaison for the project, and you are the liaison in Wyandotte, if I remember right. So
That is correct.
And I approached Jake. What was that, Jake? Like just a few weeks ago about this mapping, trying to replicate this mapping process that Wyandotte went through, and we're just trying to explore that. Before we jump in there,
drive safely.
Donna, could you just fill in Jake on who you are and what you've been up to?
Sure. So I'm Donna. If you haven't already gathered that, I am the project manager for the Health Equity Action Transformation Initiative here in Wyandotte County. We released a health equity report that was about 5 years worth of work with the Kirwan Institute for the study of race and ethnicity, looking at the connections between policy and systems and the impact on overall health outcomes. In that report, there are just a ton of maps and different data sets that we've used to really paint the picture for how systems impact health outcomes here in the county. We have some hot spotting data from the hospitals here locally, looking at patient cases and identifying them on a map and looking at hotspots related to emergency room utilization. There's a lot of data around where our moderate to high risk lead parcels are here in the county, and then a whole host of other data around vulnerable populations. We have a webpage, it's wearewyandotte.com, and there are just a ton of mapping resources that are located there as well. One of them is the opportunity map, which the Kirwan Institute has done that for several of the major cities around the country, Kansas City being one of them. And we worked with Kirwan to do some overlays where you can overlay that opportunity map over the top of some of the race data to really do some comparison about which communities are carrying the burden of lowest opportunities impacting overall health outcomes. So it's pretty cool. The website gets good traffic, and we've got a lot of interest. I'm doing a lot of heat presentations right now, so folks seem to really be interested in this work and like you all, very curious about how to replicate it in other places.
Great. And Jake, you've looked at the heat report, the physical document, the more sort of technical document, if I can call it that. In other words, not the comic book, and maybe you've also explored the website a little bit. So I just want to make sure that we're understanding what everybody knows and doesn't know and has seen and hasn't seen at this point. Am I capturing that right, Jake? Like you've gone through that document?
Yes, yeah, I've totally been through the document. I haven't explored the website though, so if you could provide that, that'd be awesome. I could check that out.
Okay, and I can send that to you later. And I don't think we need to have gone through the website to have this conversation here. But Donna, thanks for taking some time to meet with us here. I'd actually just kind of like to back up to sort of the beginning here, because to give you a little bit of context of where we're coming from, we're on Monday going to present this mapping. We've already been talking about this mapping project in our leadership team for our health equity project, and in our last meeting, which was basically a month ago, said, okay, we're going to explore more about the map and the feasibility of this, and come back to you, the leadership team, with some more background and understanding, kind of reading between the lines in the heat report that everybody's been at least mildly exposed to at this point. So I just want to be able to explain to them, give them sort of more of the story behind the maps and this kind of thing as well. So could you maybe start by just talking about like why the maps, like why did Wyandotte decide the maps in particular were worth doing?
I think there's a couple of pieces to that. I wasn't initially part of the startup of the project. That was my executive director, Jerry Jones. And we were both originally from Communities Creating Opportunity. And that organization, housed on the Missouri side doing work in Wyandotte County, they did an initial run of mapping data around emergency room utilization and fetal infant mortality rates in Jackson County, Missouri, looking at downtown Kansas City, Missouri, and working with Trim and Med. And we're able to really look and dig into this idea of where are the concentrations of people who are having a really difficult time getting access to care for either chronic disease management or prenatal care. And they really looked at those folks that were visiting the emergency room in excess of a set number of times, whatever that might have been for Truman. I know what it was for us, and I know what it is for Shawnee Mission and the work that they're doing, but it just looking at your frequent flyers in the ER and then identifying, plotting them out on a map, and doing whatever you need to do to kind of hide people's actual address locations. There's ways that you can do that in the GIS process, but getting a good idea of an overall hotspot area, and then having dialogue about how do you then begin to address the needs of those vulnerable populations through community engagement. And so through conversations with community, understanding what are the limitations, what are the pokes in the side, what is making it difficult to get access to care, and then working as a collective group or a collaboration to provide resources into those areas. And the Trim and Med group, I think they played with some mobile clinics, putting vans in these areas to help bring prenatal services to the community. And from that experience, with just looking at that hotspot hospital data, then the funders got together and talked about Wyandotte, and there was this movement to then have a similar report done for Wyandotte County. And so we started with the hospital data, looking at KU, looking at Children's Mercy data. I think there's about 45,000 patient cases that were looked at between the two hospitals. And the hotspots came out in the same areas here in the county, around the 10th and Central area, which is where we identified in both cases where people were more likely to access the emergency room for chronic disease management, and we were more likely to see readmits and returns to the ER. So we know people are going in, getting immediate experience and fix for a problem that day, going home and not having the resources that they need to continue to be healthy once they've had that Band-Aid fix in the ER. Oftentimes in those conversations, those physicians are saying, hey, go back out, see your primary care physician, here's your prescription. And these folks are going out with oftentimes no insurance, no transportation, no primary care doc, and no way to follow the orders that they were given in an emergency room setting. And that ultimately led to, okay, well, we need to understand what else is out there. Why is it the way that it is? And why do these same neighborhoods come up, regardless if it's Children's Mercy Hospital or KU Hospital or Shawnee Mission Hospital? Why do we continue to see the same populations in the emergency room? And that led us into backtracking into the data and looking for links to systems. And when you start talking about healthcare, it's really easy to link healthcare to zip code. And it's really easy to link zip code to the community and the way the community is shaped, which ultimately leads you back to policies that have shaped the way American cities look today. And so it was very easy for us to kind of make the stretch and go into this idea that the housing practices and the housing policies over the past century have really shaped the way communities look today. And then that leads to then, well, what is the ultimate outcome of that? And we start looking at all these different health indicators. So looking at what are people dying most frequently from? What is the average age of death disparity? We would have liked to have had an actual length of life measurement, but due to some data challenges, we had to go with average age of death because that's the population data that's available. And looking at things like, okay, well, we now know people are dying 20 years earlier. What are they dying from? So that draws out the cancer, the heart disease, those things that are lifted up in the reporting. And then again, we just keep asking these why questions, and it leads you into all these different areas. And you talk about average age of death, so life expectancy, then you start having conversations about, well, what does it look like from the very beginning, from birth, that took us down the road to femur. It's just one thing leading to another until we have this comprehensive, overarching piece. The mapping for us was critical because it's allowed us an opportunity to have an equity conversation in a space where that hasn't happened before, right? This idea that there's inequities in a county that's already itself part of a disparity conversation. So yes, Wyandotte County, Johnson County is just south of us. There's always that comparison, or even Kansas to Missouri. But even inside our county, we see the same challenges, right? This inequity.
Right. Good. So let me just touch on a lot of the different questions that I had. So how acceptable? Well, let me back up a second. So who have you been finding yourself having conversations with about equity? Like, in other ways, like, how are you? Can you talk more about the ways that you're sort of operationalizing that? Like, who are you talking to?
Yeah, so the community health councils, I think, uniquely situated to be a catalyst for collaboration in our county. So we have a space that provides an opportunity to bring people together. That's the start of it. And we're situated right here in downtown KCK. And we have partnerships with the local safety net clinics, the hospitals, the health department, all of those kind of key organizations, social service agencies around the county. Being in community allows us to also have a conversation as the Community Health Council. Well, we're not government, we're nonprofit, and so we can have a different relationship with residents. And so we're able to have that conversation as well. There's been a lot of folks in the academic environment that they have just latched onto this report. And so we're acting on this in a lot of different ways. So making sure that we've done presentations with the Mayor's Health Council and commissions, making sure that we've had one-on-one conversations with local elected officials and leads in government position to be able to make decisions around some of these issues. We've had conversations with obviously our medical partners and clinical partners across the county. And we started there. And for me, from the very beginning, there's this, I guess, this dream at this point that we're working on, where this is being rolled out and discussed with community by community. And so we came together and identified a few community leaders to be part of the community advisory board. And they quickly decided they didn't want to be advisory, they wanted to be action. So we're not just going to talk about it, we're going to do something about it. And so this group of people in community have sat through the presentations, asked the hard questions, worked through a root cause analysis discussion to identify where do we start to make change. And from that, they've divided out into two subgroups, one working on walkability in neighborhoods. We had a group of kids that had this really cool idea to build pride in our community, because there is this kind of collective depression in the county where there's a stigma associated being from the dot. And so part of that is this you've been told enough times that you don't matter through actions and words to the degree that you start to believe it yourself. And so how do we begin to change and take pride in our community? These kids wanted to put their names on the sidewalk in front of their house, invite their neighbors out to do the same, and talk about, this is my name, and here's one word that describes why I'm great and why it's great to be from the dot. And what we realized really quickly is it was this great, beautiful idea, but they don't have sidewalks. So like to implement this thing, they don't even have what they need to do something very simple and take pride in their community. So they decided to start working on walkability. And we've got community neighborhood volunteers, kids from the local middle school here in the Northeast, doing neighborhood audits and doing sidewalk audits with the DOT agency and KU School of Architecture and a local MBR here. That's one subgroup. The other subgroup recognized early on that people who are in decision-making power have an impact on their day-to-day life. And so they have got to take some action, and as it relates to having a meaningful conversation with elected officials beyond the doors of the commission's chamber. And so they've identified this relationship building effort for CAB members to have a relationship with those people that are in decision-making power, to be able to articulate, here's what's most important, what's most painful, what's on our plate, what does this mean to you? What are you concerned about? And to have this exchange of information to understand what their value set is, because we know values lead to decision making, and for community to be able to help inform and hopefully advocate for the things that they want. And this group has held a couple candidate forums. They're in relationship building conversations now. We just finished the election, so we've got some changes in leadership that they're going to have to work through and do some research actions with the new mayor. So there's a lot of initiatives that are underway. And then starting in January, we're taking the same community action group, which I think I sent out the last text message. We had 38 people on our distribution list in community, which is unheard of from an engagement perspective for a group to come together and work. That's a lot of folks, but they're doing great. The goal is for those folks in the Community Action Board to go through a human-centered design approach, kind of a project where they're not just doing the project and identifying a new third category to focus in on, but to also learn the elements of human-centered design so that they can continue to prototype after this group who we're bringing in leaves from community. And so it's kind of a train the trainer process, but having an actual output at the end. And so they're going to do some deep engagement, being trained to have meaningful conversations in community settings. So whether it's a dining room conversation, a living room conversation, to take elements, the 4 key topics from the heat report, have these conversations, and then bring those folks that they've had conversations back into a collective experience to workshop. How do we identify this thing we're going to work on together as a larger cohort? And so we're kind of going through that process, and we're bringing these CAB members through KLC. So we've already had 12 of them attend, which is fantastic. And then they'll be able to replicate this human-centered design approach by the time we're done with kind of this next 6 to 8 months.
Wow, that's really impressive. You're doing all of this community development, work, if we can call it that. How easy or hard would it be to do all of that same work without these maps?
The maps give us an edge when it comes to people who are naysayers. So, right, when you run into the resistance and those folks that are like, it's not as bad as you're making it out to be, then we lean into the data. And I think the other piece that's an advantage for us with the data is for the CAB members to be able to pick this thing up, right? Whether it's a video or the comic book or the report itself, or the maps from the web page. They have all these tools. They can pick it up, go into community and like present this thing in their own words. So it provides the thing to present. I think you could still do all of these things without a fancy report. There isn't anything that I think that's limiting people. I think it's giving us a little bit of an edge for the data junkies in government, right? To be able to get them to go down this process with us.
Yeah.
And for me, it's critical for this report to truly be the community's report. And I think that's one of the defining differences. This wasn't something that the local unified government put out. It isn't something that one of the local hospitals put out. It is from a community organization for the community to act upon.